Okay, welcome back to the 2021 Virtual Healthcare Confab. My name is Chris Lutz. I am with PSIC, the presenting organization of this great event. I would like to thank everyone for joining us again today on day 2 of what has been so far a great day of discussions and talking about this important issue and quite frankly, something that's not going away. I think we can all agree. To summarize, I want to first thank our MC from yesterday, Robin Gould-Soil. She did a wonderful job helping us have these discussions. We started the day with a part 3 of a very popular panel that PSIC has been happy to feature over the last few months since the pandemic hit last March. It featured Anita Feinberg and Cindy Harrison, returning, Anita being a lawyer and Cindy a practitioner with the ACT Learning Center. They really set the stage for a good day. They were able to talk about some of the lessons that they've learned since we've had to pivot, a word that we'll hear a lot for the next day and certainly for the rest of the week as the PIPA Connection Summit starts tomorrow. But they were also able to tell us where they think it's going, where they think it might be trending. And that led to another wonderful discussion from the patient's perspective. We had Carla Heggie and Ambrosia Vedeskin speaking to us with their experiences from being people who have suffered from chronic conditions from an early age. And we wanted to know, was it more difficult or did it change how they advocated for themselves and their treatment and care post-COVID when it was only virtual? Some really interesting points that came out of that led beautifully into our last discussion of the day, which was talking about remote consult services that already exist in Canada, things for our Ontario audience, e-consult, a big tool that's being used, the RACE tool that we covered, some great things, and it was a natural progression. And so I am thrilled today to start with a panel of practitioners and privacy professionals, both from an oversight or expertise side. And I couldn't be happier to kick off the day with this panel that will then lead into other sessions about more tools. We have Health Canada joining us today to talk about the COVID tool that was quite frankly revolutionary, not only within our country that we started using it, but I know other nations across the globe modeled after it as well. And then we finish with another example of cyber in this new world of virtual care with our friends from High Rock. So it's going to be a great day. I would like to thank everyone for tuning in on the live stream, as well as those of you that are on this Zoom call. Again, my name's Chris. Use the chat to ask me any questions you have. So today, I am very excited to present our opening panel, and I am going to let these wonderful panelists introduce themselves to the audience. But first, I would like to welcome Rachel Hayward from Alberta's Office of the Information and Privacy Commissioner, Simeon Kanev, who is from the Alliance for Healthier Communities, Dr. Rod Lim from the London Health Sciences Centre, as well as Dr. Neil Merritt, also from LHSC and St. Joe's Health Centre in the London area. Thank you to all 4 of you for coming. The first thing that I would like to do is, in your own words, if you wouldn't mind introducing yourselves to the audience, and we'll start with Rachel.
Well, welcome everyone. I'm very excited to be here. This is, I think, obviously a very timely conversation, and hopefully I'll be able to provide you with some insight and thoughts from a regulator's perspective today. So one thing I guess I should tell you about is I am from Alberta. So I work for the Alberta Privacy Commissioner's Office. My title there is Director of Compliance and Special Investigations. So I'm responsible for all of the self-reported breaches that are reported into our office. They all have to run through me and my team, and as well as all of the privacy impact assessments. And then we also are responsible for all of the special investigations. So that includes our regulatory offense investigations, as well as other investigations that we might have on the go, what we call them is investigations generated by the commissioner. So something else that the commissioner has deemed to be of public value to investigate. So we do those as well. I've been with privacy for, I think it's about 15 years now, and certainly with the commissioner's office for 10, and I've been director for about the last 4 now. So that's a little about me.
Thank you, Rachel. I should also say that Rachel and her colleagues at Alberta's office are very active supporters of PSIC and the events we do. So thank you for that, Rachel. Neil, nice to meet you.
Yes, likewise. Thanks a lot, Chris. I'm absolutely delighted to be here and join the rest of our panelists to discuss something that's sort of certainly taken over my life recently. Briefly, I'm a pediatric surgeon at the Children's Hospital in London, and I practice basic pediatric surgery. The things that keep me up at night include appendicitis, so that's the most common sort of operation I do. But we do everything from surgical operations in small babies to teenagers. I'm also the medical director of pediatric trauma, and recently took on the physician lead of virtual care across our organization. Privacy and risk is sort of crossed my mind several times in the last several months. Like everyone here, we all had to pivot. Like you said, you're going to hear a lot of that word pivot fairly quickly when this pandemic started. And for me, that meant that, I may have been seeing one or two patients a year virtually. Now, and this literally happened overnight, I may be seeing up to 75% of my patients virtually. And that's introduced all sorts of new considerations around risk and privacy. And so, I'm learning stuff every day, and I enjoy the conversation. So thank you to everyone who's listening today, and thank you to my fellow panelists for the invitation. Thanks, Chris.
Thank you, Neil. Please introduce yourself.
Hi there, and thank you. I'm really thrilled to be here as well. Just a little bit of background of myself. I do work at the Children's Hospital in London, Ontario as well. I'm a pediatric emergency physician. I've been at London as in that role for about 20 years. I've been site chief for about 12 years and medical director for about 2 or 3 years now. Prior to COVID, I saw 0 patients virtually. Didn't even know what Zoom was really, something my kids did. But boy, what a year we've had, right? So during the pandemic, our volumes dramatically dropped, and we knew from the experience that patients were really hesitant to seek medical care. And born out of necessity and speed, we quickly pivoted to a virtual urgent care offering that we set up within weeks and was physician run about 3 or 4 hours a day, 7 days a week since last May. And so we've been up and running. We had lots of learnings. There is lots of privacy, health, and risk considerations. And we've recently been part of the Ontario Health pilot project for virtual care. And so we've expanded across organizations with Hamilton leading the adult service. We've made a combined service, which created a lot of risk and privacy issues as well. We expanded our clinic yesterday to 8 hours, added a website, added a toll-free number, added additional staff, and we've had to work through all of those considerations, not only risk privacy, but of union and hours, and there's just a million things that we had to navigate because we were breaking new ground. That's really given me quite an insight on the complexity of this really important but learning and ever-changing environment. So I'm very happy to talk from the practitioner side. So thank you.
Thanks, Rod. I appreciate that. And Simeon, on to you. I would like to also remind our audience that tomorrow and Thursday, PSIC is also presenting its annual conference that has been running since, I believe, 2000 and, I'm not going to guess, for a long time, called the PHIPIC Connections Summit. And the Alliance for Healthier Communities is our honorary host. So Simeon, please introduce yourself.
Thank you, Chris. I'll make sure I'm not on mute. So my name is Simeon Kanev. I'm the privacy business lead at the Alliance for Healthier Communities. It's a pleasure for me to be here, and thank you for the invitation to present with my co-panelists here. I've been in the privacy field in the healthcare sector for the past 10, perhaps 11 years, and I really love doing what I do. Trying to make privacy interesting, exciting, and more importantly, practical is what I strive every single day. Because let's put it in this way, everybody knows the theory. Like most people know the theory, but putting that into practice is what makes it or breaks it, really. Because you've heard this before, privacy is a barrier versus privacy is an enabler. I live under that every single day. That's my motto, like make it an enabler, not a barrier. I've seen privacy from different perspectives. I've been in the hospital world and in CCC world when they were a thing. And now I've been for the past almost 6 years in the primary care field. So I've had my fair share of helping folks understand better what privacy actually is and what it means, try to demystify concepts. And I provide support to 107 member organizations scattered across the province of Ontario, anywhere from a small shop of 10, 12 people somewhere in North Rural Ontario to another big one in the middle of downtown Toronto. And we service and our members serve those that face socioeconomic barriers to health. So a number of other considerations that one should have when talking about privacy. In terms of the the lovely world of virtual care that we all now live in, well, it is fascinating because it's both effective and efficient. It's not going anywhere. From now on, it's going to be there for at least, I would argue, 50% of what we've done before, because it's quick and it's easy. There is no need to go and lose time in someone's waiting room and wait there and so on and forth. So we've proven that this works. Now we have to polish the kinks of when it comes to privacy, security, confidentiality, and so on and so forth. So that's what I guess what we're going to talk about today. And how do we bridge that gap between the providers and us folks that are trying to make sure that we are compliant with everything? Because we can find a common language, I'm pretty sure, in that.
Well, for one thing, I see a lot of nodding heads, which is good. And the second thing is Simeon stole my job, which was the segue into the question. But I did want to frame our discussion for those in the audience that aren't familiar with PSIC events. Typically, we look at issues specifically for information professionals in the public service through a privacy and access lens. And so, but for this particular event, that hasn't been the only lens that's guided the discussion. But today, for the sake of this panel, it will be. And as Simeon mentioned, the title of the presentation is Closing the Gap. And that's an assumption on my part and the people that made the agenda. So I'm going to go around the room and ask you what you think the biggest gaps are between privacy and practice. And if you need to use and frame your answer with your own experiences, obviously, all the better. I'd like to start with Neil.
Yeah, wonderful. So you know what, I sort of subscribe to a similar sort of philosophy that Simeon's outlined. I think that it's all about how you sort of see privacy, and privacy does actually need to be an enabler, and we should be sort of interacting together. Those of us that are sort of in the realm of providing care and all the associated privacy and risk issues around that, we need to be interacting more regularly with our privacy experts. And one of the things that I noticed that actually occurred with our pivot to virtual care was actually I was spending a lot more time discussing things across the organization with our privacy and risk experts. What I realized actually is that that as we digitized processes, we created new risks to the organization. And so as I provide virtual care, even as we look at a variety of different platforms that can be used, there was new risk that was introduced into the physician-patient relationship, and that risk had never existed before in the same way. And that's just one example. There are so many examples. Writing prescriptions. How do you digitize that process? Remote patient monitoring tools. What I really think happened was that we had this vast sort of data that we were generating in our virtual care processes, and that data was experiencing some new vulnerabilities, and I think things that we had probably never considered in the past, and so that really sort of made us, I think, as clinicians, and I think Rod would agree as well. I know I work closely with Rod in the emergency department, that this sort of new relationship with risk and privacy has actually been very much a benefit for us as clinicians. I think we have learned a lot, and we've been able to do things in a way that's ultimately going to deliver high quality, safe care for our patients. So I think that's how privacy has really touched me recently, and touched our organization, particularly as we sort of make a transition to virtual care that's going to be around for a while. Our organization has set a goal of about 60% of patient visits being virtually. So 6 out of 10 patients we're now going to see virtually. So this is an incredible new risk and a new benefit as well to the organization. And so, I obviously very excited to be on that road with everyone here on the panel.
Well, thanks, Neil. And I'm going to go to Rod next. Rod, do you share the same enthusiasm and the same optimism as Neil as a physician yourself?
Yes and no. Yeah, for sure. I think the benefits are pretty obvious to everyone involved. I think this has jump-started something that had really trouble with inertia for quite a few years. The technology was there, but I think the willingness may not have been. And the COVID crisis has really jump-started this, and I think there's no going back. I don't think there's any question about that. So for sure, I'm enthusiastic about it. Bad time to ask me, having just tried to set up a clinic, in terms of all the roadblocks and processes I have had to go through. But it's just such a fascinating thing when I think about it, right? Because a lot of the things that we decide in terms of like standard of care and things like that have been determined over decades. The physician-patient relationship has been sacred. That's something that we've talked about for the entire evolution of medicine. And we've been slowly introduced to more risks in terms of privacy and security related to Facebook and our use of social media, electronic patient records. But in some ways, they've been enclosed systems. We're still, between us and the patient, there was nothing. We still physically saw them. And what we're doing now is we're interposing between me and the patient a new thing that we never had to consider: the technology, the vulnerabilities. This is a very giant leap to put that process between the patient and the doctor. If I made the analogy that in my emergency room, I would suddenly blow the roof off, and maybe the person in the parking lot can now hear my conversation. That's like a huge, gigantic shift in terms of the way we think about risk and privacy that we didn't have to think about prior to that. Someone intercepting my words between me and the patient, we never had to worry about. But now there's there's a lot that goes between me and the patient now. So these are huge, huge things that are, basically, things that we need to consider very carefully. And we need to forge those relationships, not only with risk and privacy, but with IT and with legal, with all these things, because now we're all between me and the patient. And that's just such a new relationship. The other thing that I find that's a big gap is, in some ways, when we develop these kind of technologies, EMR or whatnot, they didn't really need to understand what I was going to do with the patient. But now, when I say I'm going to be doing this, the person that's going to try to make that determination about privacy risk may not actually understand the nature of the conversation or what has to take place, and what would be within standard of care. So there's a little disconnect between so you want to ask what you're going to ask this adolescent, but what if the parent can hear now? What if they can't get the parent out? What if they disclose that they're actually in harm's way or being abused? How are you going to handle that? So these are the types of questions that I get from risk and privacy that I wouldn't have to consider in a physical visit. And usually in big institutions, their go-to answer is, find me another institution that has done this for 10 years and tell me what the standard is. But it doesn't exist. And I think that's what is the most exciting and the most difficult, is that all the people are looking around saying, do you think that should be done? I don't know. And they go to the insurers and say, would you insure this? Would you not insure this? And the insurers are going, I don't know what you're talking about. So, there's just such new ground that we have to develop. But I think, the effort is there, and the reason we were trying to do this is there for the patient. So I think it will succeed in the end.
Well, it's funny you should mention, I've heard now the word standards mentioned a few times, and we're going to touch on that in a bit. But you're right, standards have had generations of time to have been developed, whereas privacy policy isn't quite that old. But it's starting to be considered along the same lines as standards. And it's interesting. I bet you Simeon, who I'm going to go to next, would argue that the first person you should check with when it comes to privacy would not be legal and would not be IT, but would be someone like him. Simeon?
Well, let's put it this way. The way I see it is there has always been a gap between anybody delivering care and the people responsible for compliance, like myself and my colleagues in the field. That has been always there. Now it has been enhanced, exacerbated by COVID, where all of a sudden everybody needed to switch things to virtual way of communication. And naturally, many different tools appeared out of nowhere, some bit more kind of like better than others and more transparent than others. And ultimately, it came down to, okay, the privacy police is coming. I've heard that a lot, many times in my life. Now, like, oh, we have an issue. No, not necessarily. I will work with you to make things work, not to give you a hard stop. No, that's not going to happen. Ultimately, at the end of the day, we're all here to do one thing: deliver the best care we can to the patient, or the client is the terminology that we use. So the way I look at this is there is a common ground that we can all find. It's just like people need to be able to compromise to the degree where everybody can basically be serviced properly. The client patient can be serviced properly. The organization is sure that they've done the reasonable in the circumstances, because then the regulator would justify, anything that can happen. Hey, the organization has done what's reasonable in the circumstances, and I'll keep repeating that phrase because I firmly believe in it. You only need to do what's reasonable in the circumstances. And many things have changed in the past 13 months when after the whole pandemic took over, and we needed to change the way we live and the way we operate. So I really think that there is a ground that we can find common ground to bridge that gap. It's not going to happen overnight, that's for sure, but I guess we'll work together to make that happen.
Thanks, Simeon. And Rachel, what's your perceived opinion of the gap? And or maybe there isn't one. I don't know. What are your thoughts?
I think there's always been a gap, and I think that I think it's actually an exciting opportunity right now. If we can find something positive coming out of the pandemic, let's look at this as an opportunity. For a long time, we've had privacy folks trying to explain risk and risks to practitioners. And practitioners are focused on their role, which is providing care. Privacy is focused on protecting the information that the practitioners are collecting, using, and disclosing in order to provide that care. And there's been not enough collaboration. So what I think is where the biggest gap is that there's not enough understanding of risk. And this opportunity, if we're going to call it that, and I'm trying to find things to be positive about these days, right? This opportunity really starts to demonstrate that there's a huge gap in understanding about risk. So my advice is and how do we bridge this gap? Let the experts do their job, and really be open to listening to the experts. And so what that means is the experts in privacy need to be able to look at products before they're used. The expert practitioners need to be able to say, I can't, this product doesn't allow me to do what I need to do from a distance perspective, and I need something that does this. We need more collaboration and more everybody coming to the table without those preconceived ideas of, well, privacy is, they're going to slow this down or prevent things from moving in the direction we need to move, and we need to move quickly. I think both Neil and Rod raised some really good points around things like the data generation that we're creating, all this data that's being collected, used, and potentially disclosed. And the privacy folks, the people focused on risk, are saying, oh my goodness, there's so much more data that we're collecting now that's potentially available. There's all this more risk associated with it. and trying to focus on that, but and trying to focus on protecting that information and ensuring that we actually need it. In my experience, there's a lot of products that are being used out in virtual care right now that might actually be collecting stuff that the practitioners don't need to do their job. So it's an overcollection. So why have the added risk, right? And so the ability to come together and find some time to come together and start talking about um, everybody's expertise, bringing everybody's expertise to the table. The privacy experts, the legal experts, the IT folks who say our IT infrastructure doesn't allow for a product like this to be used. And also the practitioners need to be front and center of that and saying, we don't need all this data that's being collected here. This isn't required for us. Or we need the product to actually be able to go a step further and to do this for us as well and interact with patients in this way. So I think there's a big gap in the understanding of what that risk is, and I think that it's become so obvious now since the pandemic that it brings with it this opportunity for us to actually sit down and renew that relationship and work together to try and find a better way to do what needs to be done, and hopefully in a fairly efficient manner as well.
Well, thanks, Rachel. I'm glad you mentioned products, because that's where we're going to head to next. Not only did we have an opportunity to learn about some yesterday, we're going to have a case study this afternoon, and it goes without saying that we, the global we, have had to adopt new technologies, new third-party solutions to continue to, in your case, provide care. But with that, and with the speed with which we've been forced to adopt those tools, comes a lot of risk. So can we talk about the risk versus benefit tug of war? I mean, there's a need, there's a risk. How do we assess that? What do we do to make sure we're being responsible? Rachel, I don't know if you want to make a few more comments before I go back to Simeon, and then we'll end with our doctors.
Sure. I actually think that when you're looking at a new product, a new virtual care product, I think really the key is to look at it like this. You wouldn't get married to somebody who's your family doesn't know, who you've never met, your family's never met, nobody's ever heard of, and you have no actual experience or connection with that individual, right? Like, and yet you're going to be sharing your tax information, your financial information, all of your personal information around your family, your health with that individual, right? It's kind of like that TV show that my teenager is obsessed with, Love It, Marriage at First Sight, I think it's called. You wouldn't do that, right? Like, you'd at least have family or somebody get to know that individual on your behalf in most cases, right? So it's the same thing. When we're taking a product and we're looking at it, we need to have the time to have experts look at what that product is. That's where the risk is, right? There's great benefit to being able to provide and use some of these products, but the risk, and I'm probably better at talking more about the risk, I think, than the benefits, because that's where I always have to focus when I review these things, right? There's so many products on the market right now that a lot of the risks are hard to see. And as was already mentioned, this is such brand new territory, and we're breaking new ground here, right? So there isn't a lot of experience, and we even suggest, like, check and see other clinics if they're using the product, right? And we try and get people engaged and talking to each other, but we can't rely on that now. So this is again where we need those experts to go in and actually look at it. And here in Alberta, privacy impact assessments are required, and I know that they're not elsewhere in the country, but it's a great way to make sure that you're looking at some of the risks. There's a lot of risks with these virtual care products, and risks that we've never really had to consider before. The number of third parties that are being used in these products, because these products are being developed because they themselves are developing themselves very quickly to meet the market need, right? And so they're relying on a lot of third parties, and those third parties could be located in other countries. They could have very little security themselves, right? So there's a lot of risk that's associated with it. So it's really important to take the time to get to know the product, and don't trust the product outright because it's providing you with what you need. Take the time to get to know that product a little bit, and take the time to read the agreements, or get somebody else to get the legal experts and the IT experts to take a look at it. And I'm always an advocate of privacy impact assessments, and that's a great way, really, to have somebody review those, review and look at the risks, and make sure that you are prepared to undertake any risks that can't be mitigated. I would say that's something that we've seen since COVID, is that practitioners, well, we call them health custodians, aren't always aware of the risks that they're putting themselves in, their patients' information in, by quickly adopting a product. And then there's a lot of backtracking, and trust me, the work to fix that is way more work to fix that on the back end than the work in the front end.
Thanks, Rachel. Simeon, I'm going to just for a second ask Rod and Neil for their comments, because I think that they're in a unique situation in this particular dynamic to be the ones who know what the benefits are, whereas privacy professionals might not, right? Like, they're looking at the tangible benefits they get from a tool to practice care, and they wouldn't necessarily be in the know about what other data it's collecting that it doesn't have to. So on the benefits side, what have Neil and Rod, what have you tried to do since last March or February to, just to balance risk and benefit?
Yeah, it's such a quick moving, thing. I mean, the reason these are proliferating is because the need is so diverse, and the solutions need to be found very quickly. We can't wait till 6 months from now. The COVID will hopefully be a very different state than it is now. So these are born out of necessity, and 100%, we need to be hand in hand with privacy, because they certainly will understand the things that we are not considering. Like where this information is being stored, how's that going to be handed off, what are the vulnerabilities. But sometimes, depending on the size of your organization and the immense need that we're talking about, these could be small organizations or organizations that don't have a huge track record of going into this space. So they may not know what they don't know as well. And I think that's where, the benefit is definitely the flexibility and the speed of which we need these solutions to work for us to start being able to provide effective care, for sure. But there isn't this huge, track record. It's almost like when cell phones first came out, you didn't know which provider was going to end up being reliable. You kind of looked between a bunch of different suitors at that point, and everyone has a different level of expertise on that. So I can totally understand kind of how we're, where we are. And I think that's where sharing knowledge and talking about these issues are just so important.
Yeah, I would agree and echo sort of what Rod has said. I think at the start of this pandemic, the things that caught my attention were the things that would deliver what I needed to be delivered for good, safe, high quality patient care. And frankly, I really, there wasn't much consideration given to the risk and privacy issue. Really, what was front and center in my mind was I was unable to see a patient. There was a patient out there, I was unable to see them. They were receiving no care. And so, we had to very quickly figure out how to provide that patient with care. And frankly, it was like the Wild West of solutions. There were all sorts of options out there, including options that were homegrown out of the garage, if you will. And this is the sort of thing that we faced, and it was very overwhelming. In fact, I mean, which solution do I use? And your eyes get attracted to the solution that perhaps does the best at marketing its solution, not perhaps the best solution with the privacy and risk standards in mind. And that's how this pandemic started. And as we've previously talked about, it created this opportunity now to go, wow, we need to consider these issues. I can't just pick the sexiest virtual care solution. I actually have to put some thought into this. And now I'm at privacy and risk, and I'm at privacy and risk far more often, not because I'm getting my knuckles wrapped, but because I want to be there. I actually want to be there, and I want to engage in a conversation, and I want to know, how I can deliver the care that I need to deliver in a safe way. I also want to pick up what Rachel was saying about the structures that exist around privacy and risk that guarantee or at least improve your chances of selecting a solution that addresses these issues, and that is the threat risk assessment and the privacy impact assessment. I think those are two very key things whenever you consider a solution. And I would even go so far as to say that our own government at the level of Ontario Health has recognized the importance of that process. In fact, Ontario Health, through OTN, which is Ontario Telehealth Network, has designated a virtual visit verification process. And that virtual visit verification process involves all these vendors coming to Ontario Health, going through a privacy impact assessment, a threat risk assessment, answering a whole bunch of questions, and then being verified as a virtual visit solution. So that, as providers, we can look to what solutions already exist out there that have went through this verification process. And furthermore, the government has realized that if you really want to control what solutions are used, you tie remuneration, physician remuneration, to the solution they use. So if you're not using a verified virtual visit solution that's gone through all of the criteria, then you're not going to get paid for the care you provide. So it's a big deal. And I think, like the panelists are saying, we need to provide care. We need to provide high quality and safe care, but we need to do it in conjunction with our partners at risk and privacy.
Well, Simeon, we're going to get your comments here, and I think you're in the perfect scenario here where you constantly are in communication with both sides of this.
Well, it's beautiful, that I went last year because we just heard the two sides of the gap we're actually addressing right here. What us, the compliance people, are talking about, privacy, security considerations, because privacy and security are two sides of the same coin, and what the providers want on the other end, which is the benefits, what this allows me to do. I don't care what goes where. I mean, Neil is an exception of the rule, really, because he's actually seeing things from our perspective, which you don't see very often. But the point is, they want to do a tool that works. The very tool we're using right now, I'm just going to give it as an example. When we started the whole journey, that was a great tool because it was simple graphic user interface. It was working for what it was worth, and it was easy for everybody to use. It didn't require anything like fancy training course and whatnot. But then folks like myself and others in the compliance field saw it as, wait a second, where is this hosted? Where does the information go? And there were a number of things that came out to be problematic. Hey, guess what? They addressed them in a quick, very timely fashion, actually. And we actually managed to find a way to make things work so that both sides of the equation are happy. But it was work together to make this happen. It wasn't easy, but we proved that we can go there. Because we can say all we want, we have to do this and then we have to do that, and no, this doesn't work. We need to find that language, common language, to make this work, because in order to understand a problem, you have to put yourself in the shoes of the other ones on the other end. Otherwise, it's not going to work. Again, going back to practical versus theoretical. And I want to allude now to another term that came not that long ago, and the first time I heard it was from an esteemed colleague of mine who is also a lawyer. The term is privacy paralysis. And it's interesting. It's an interesting term because it basically means the state that one goes, most typically in the front lines, in the healthcare field, that basically they're so afraid to not make a mistake, to not disclose inappropriately information or collect and basically snoop into records, that they're going to be doing nothing. They basically just shut down and don't want to share anything, don't want to do anything. That's the state of privacy paralysis. The reason why we go there is quite often because of the way privacy is presented. It's presented in a way that it makes it sounds like this scary, the scarecrow, right? That is always there, always watching, almost like the Big Brother concept. And it's like people think that, when they snoop into a record, the privacy officer will storm in their office before they can shut down their machine, right? And that's not how the world works. The point is, this has to be done properly. This has to be explained properly, the whole concept of privacy. And I've done a lot of training myself, and I believe this is the key to bridging that gap. Proper training to folks where it's not done with theory and killing people with concepts and theory and definitions. Because let me tell you, the trainees will forget what consent directive is 30 seconds after you define what it is. What they will remember is the examples that are relevant to them and the jokes. Those are the two things that will stick with them for a very long time. And make them interesting, make them exciting, and people will pay attention. People will believe in what we all try to achieve here. And I would like to see, what the other perspectives are here from the other panelists on this concept of privacy paralysis, particularly really from the frontline folks here that we have, Neil and Roderick. Have you ever experienced that before?
It's a great segue for a good joke, actually, Simeon. I feel like I need a good joke now. Actually, I don't know if any of the panelists have a good joke. I don't have one right away, but having said that, I think no. You know what? You're right. We do need to sort of understand each other better, and we need to get in front of each other more. Like we are today. I think this sort of event also provides a great opportunity to come together and talk about our respective outlook on this issue. And so it's very important. And I am biased. As the physician lead of virtual care, the agenda is to see virtual care rapidly adopted and implemented across the organization. And to do that, we can't get into privacy paralysis. We simply cannot do that, or we're not going to achieve the overall objective, the vision of the organization. So in my mind, it's imperative that we're together, we're charting territory out together, that we have clear structures that we adhere to, as we sort of bring things forward. And while we do that, we don't allow that to paralyze us. I'll illustrate with a recent example. We have been looking at solutions to collect consent at a distance, consent for operative procedures. Practically a very difficult sort of barrier, because we have been entrenched in how we collect consent. It involves a wet signature. It involves, a written document that's on the chart that comes up with the patient. But hey, the reality is we've gone to an electronic health record. We've had to pivot to virtual care. I may not see the patient until the day of their operation. And it's really inefficient if I have to walk out and get their consent the day of the operation. And so we really had to bring all the stakeholders together. And this speaks to what Rod and Rachel were saying. It is more than privacy and risk. It's all the stakeholders. We had to bring them all together to understand how we were going to achieve this. And there was a point where I think we sort of got into this privacy paralysis, this sort of scenario where we weren't moving a solution forward. And that typically represented a time where, it's interesting. It usually represented a time where all the stakeholders were not in the room together. If you brought everyone together, suddenly things could be done. But if we were apart, if all the stakeholders were apart, you got into this problem of not acknowledging, recognizing, and working with your other partners. And that is so very important to avoid this privacy paralysis issue. So I personally have just been thrilled to have opportunities that I've never had before to engage all these stakeholders and to move this forward. And that's the only way you move it forward is with conversation.
Rod, a very collaborative point of view when it comes to what we've been doing over the last year. Any comments? Do you have the same kind of stance as Neil?
Yeah, just a brief comment. I think just like we talk about how now between me and the patient is all these new relationships. I think we really need to think about not having a privacy sign off as opposed to a beginning of the process of working together for a yes. And I think a lot of organizations are set up that these are checkpoints. So you do all the work, you figure it out, you work amongst yourselves, and then you bring it to privacy, you bring it to risk, you bring it to everything for sign off. And you put them in a very difficult situation because now they may see very legitimate points that need to be worked through, but it feels like there's a barrier, like a hard stop. And I think, if we resource everything properly and we develop these relationships where we're working together early, by the time we get to sign off, everyone already knows and have worked through the problems. And I think, we need to rethink of the way that we engage people and the timing of it.
Rachel, I wanted to get you get your comments on the notion of privacy paralysis. Funny enough, it's a term that is not certainly exclusive to the health community. It you are part of an oversight body that has relationships with more than simply the health community. So I wanted to get your comments on that, and I wanted to know, is policy the way out of this? Like, where do we go?
I don't think policy is cure-all for anything. I think policies help. They're a good start. But in my experience, when we, unfortunately, when we have to investigate a health organization and we say, okay, according to your privacy impact assessment you submitted to us 6 months ago, you have policies and procedures, can I see them? And they have no idea where they are, and they've never seen them. Nobody's ever signed off on them. And it turns out that they're in a literally paper bound in a binder in a clinic that nobody's ever opened. So they're only as good as if they're actually being followed. I think that there's great potential to that, as long as you institute a practice where people are actually looking at them and following policies regularly and starting to rely on them. One of the things that we've seen in virtual care, though, that I will point out because we're talking about policies, is that with a lot of products that have been submitted for privacy impact assessment reviews, we don't see a policy related to virtual care. So they don't actually talk about how you plan on providing that virtual care. And this is key. In Alberta, we have requirements like, how are you going to explain, you have to tell people why you're collecting the information you're collecting, even though it might be obvious in some cases. And you have to, but virtual care products, a lot of them don't do that. So that means you have to do that. So that needs to be written in a policy. Are you going to be collecting, are you videotaping this? Are you collecting audio of the encounter? Individuals won't think of that. Remember, they're never in their best case when they're coming for healthcare, right? So they're not going to think about that. So there needs to be a policy in place that says we collect when, or we don't collect, or whatever other practices that you have to consider when you're. And I won't go into all of them. Because it's going to depend on what the virtual care product is and a number of other things. But that's one thing that we've seen is greatly missing is no one's thought about, this is a really different way to provide care. So let's write some ground rules so that we're all providing care in a similar way, so that if somebody else has to look at my health records or my patient's health records when I'm on vacation, they're going to be able to find the information they need, or for whatever other purpose, right? Or we're providing care in a similar way so patients know what to expect when they come to this facility. Really, really key things that I think are missing. Policy is a great place to start. I think it's really, really important. We consider it to be a mandatory administrative safeguard to have policies in place. But there needs to be more than that. And unfortunately, this is one of those things where it really needs to be in place before you start using a product, so that you've got some consistency, so that patients know what to expect, and so that practitioners as well know what they're supposed to do and what their rules are, and how they can feel comfortable. Policies are like rules or laws. When you read them, you know where your boundaries are, right? And as kids, boundaries are a safe place, right? You know where you can live within. And as adults, we're sort of the same thing. We want to have those policies in place so that we know what we're doing is okay. So I think it's something that's missing. And just briefly on privacy paralysis, I've seen it so many times, and I find it quite upsetting, actually, because a lot of times it's like, well, I couldn't disclose the information about imminent harm to this patient because of privacy. No, absolutely, you could have, right? Because there was an imminent harm issue. And so it's the fear of the unknown, and having policies in place, and having those policies available and easy to access and maybe on everybody's desk, will help eliminate and reduce that, or at least reduce that fear. And that hopefully the policy will say, okay, I can record this, or I can, take audio of this because it says so in my policy. And so people will get some comfort from doing that. Policies can definitely play a role in reducing that privacy paralysis. But I think it's mostly out of fear and not knowing, where not knowing enough about the privacy rules within the organization that creates that privacy paralysis.
And Chris, I wanted to add a quick point there because I thought of a joke actually that because Neil prompted me on that, because I think it will actually bridge the whole privacy paralysis thing with the opposite part of the equation, where somebody might say, well, I didn't share the name, but it was something else that I thought of doing. So I would risk of that joke probably being perceived differently by different people. When GDPR came into effect in Europe as one of those draconian measures for data protection, there was this joke about this crowded waiting room for a healthcare provider where the receptionist comes into the crowded waiting room and says, because of the new regulation, we cannot call you by name, may I please ask the gentleman with syphilis to please come in? Obviously, that's not the way to do it. But at the same time, you're thinking of, okay, people, privacy paralysis, I cannot share the name, maybe I can share something else. And they might unfortunately do something worse than sharing or identifying someone by their name or another identifier through different means. So kind of like to piggyback on what Rachel said, policies, procedures, all of those documents are necessary. Some see them as necessary evil, but they're necessary. And what's even more important is that they're enforced. Because if they're not, it's just a piece of paper. It's a document sitting there on the shared drive. And last time it was updated was 10 years ago. And that's useless, right? So that's where, again, we need to find that common ground that works for everybody. I firmly believe that. So.
Well, as predicted, the session flew by. We are technically 5 minutes into the Q&A period of the roundtable, and I didn't technically even ask all the questions that I had written down, but for the sake of being inclusive and the fact that I have a good question here from a delegate, I think what I'd like to do is get your comments on the question itself and any kind of closing comments you have, because we do have to wrap up in 5 minutes. This is the world of live TV after all. And so the question is, does anyone want to comment on the record keeping implications? And I'd be curious to know specifically what Neil and Rod say about this, because I don't know if there's another layer of people administrative role, between you and that record getting filed. But do people want to comment on the record keeping implications, on standards of care and use of virtual tools? What new types of records are being created, video recorded visit, for example, and how are they managed, or how will they be managed?
I'll start off, if that's all right, Rod, with that question. That's a fantastic question, first of all. So this is exactly what I face personally every day, is the generation of massive amounts of health information and how we sort of attach that to the health record. So it starts with the electronic health record. So, the issue is that you can be in an environment or ecosystem where there are many different electronic health records, and none of them talk to each other. So that you're collecting information, you want to sort of provide that information to the electronic health record, which ultimately should be the space that you store all of the patient's health information in. But you can't do that because there's no interoperability. So one of the things that has to change in the future to allow for seamless exchange of health information, and as we generate more and more health information, we're going to need to solve this problem, is the application programming interfaces, the APIs that need to exist that allow you to exchange health information in a seamless fashion and that subscribe to the privacy and risk policies. So in terms of, new solutions for that, I can only speak to the enterprise electronic health record we use at London Health Sciences and St. Joseph's Healthcare in London. And that is a Cerner electronic health record. And we are within a few months of actually rolling out a suite of APIs that will allow us to exchange seamlessly and in an ordered fashion information from our video visit solution, information from our remote patient monitoring tools, information from prescriptions that are given to patients. So we are very close to having the interoperability required in our electronic health record to do some of this. I say we're very close, but I'll also say we're very far. It was the best of times and it was the worst of times. So we are close, but we're very far. But that ultimately, that interoperability is going to be key. Otherwise, you have all these data lakes and you're not sharing. And those data lakes represent privacy risks. And so, if you do not have a way to bring everything into sort of one cohesive record, I think you're accepting far more risk. And so, so this is a fantastic question. It's something we're on the ground looking at right now. And ultimately, it's probably going to require a new way of thinking about health information. And this may spill out to blockchain, and to, treating health information on the blockchain in a way that allows patients actually to own their information and share all of that information with their providers. So now it's not the electronic health record, it's the blockchain, which may be a part of the electronic health record, but that allows seamless integration and sharing of information. So this is a great question, and we are actively working on that as an organization, and we need to find a solution, or we're going to have a lot of problems, I think, as we generate all these data lakes.
Thanks, Neil. We've got like 2 minutes left, and Rachel, I know you want to make a few comments. Rod, do you have anything to add?
I just tie it with a bow and say, we're lucky that we developed ours within our electronic patient record, so that a lot of the things that we don't have to think about were okay. But you can imagine that if we didn't, like the privacy people and the hospital may not understand that if I'm writing something down at my house with patient information, all those risks and securities that's going to provide. So it just speaks again to really understanding each other, changing the order that we talk to each other and working together as a team. And I'll leave it at that.
Thanks, Rod. Rachel.
So I wanted to speak to this really briefly because this is really key to a lot of what we're looking at when it comes to virtual care. So I think Neil's right. This is a fantastic question. A cohesive record, extremely important. But from a regulator perspective, what I'd like to leave you with is just because you can collect it doesn't mean you should. So ask yourself, do I need a recording of the visit? Do I need it? Maybe you do, maybe you don't. And in the UK, there was not that long ago a breach by a company that's also in Canada that has a virtual care product. And what was breached? All the videos that they were recording. So those extremely personal connections between patient and healthcare provider were breached. We can collect a huge amount of information with virtual care products, but my caution would be only collect what's actually needed. And to ask yourself and to ask the experts, ask the practitioners, do you need the video recording, or is something like an audio recording enough, or do you not need either? Because you're also taking notes, as Rod had said, and those notes are going to be input into the health record as well. So just because you can doesn't mean you should collect that information.
Very good practical advice that anyone collecting PI should employ, regardless of the field that you work in. Unfortunately, even though this is amazing, I do have to wrap it up. I did want to make a plug for specifically a panel that Simeon is on tomorrow. I'm not sure. Rachel, are you also on the ransomware panel? I don't know off the top of my head, but both Rachel and Simeon will be joining us for the PHIPA Summit, Connections Summit tomorrow and Thursday. And on the agenda, it's specific to the healthcare community. I don't think ransomware attacks are necessarily new just since COVID, but nevertheless, ransomware, which, also weaves its way in through the discussion, specifically when it comes to third-party IT solutions. But with that said, I want to give just a loud round of applause. Thank you to our panelists, to Simeon, Neil, Rod, and Rachel. It was wonderful. To our viewers online, we will resume at 20 to the hour, so 1:40 Eastern time. We have a short break now. To those of you that are on the call, if you want to stick around and ask a question after, I invite you to do so. But for now, thanks very much to our panel. Great.